Good morning, one and all. So today I am Dr. Shubham. I am working as a clinical pharmacologist in Jupiter Lifeline Hospital. So here's our next presentation in critical care forum, pharmacokinetics and pharmacodynamics in critically ill patients. So today I am inviting Dr. Shravani Etrud, graduated in 2022. She from her graduation, she's working at AIG hospitals in critical care from 2022 to 2024. Recently, she has switched in cardiology department and joined the FCPI forum in critical care forum in January 2024. She is also a member to ASCPT and served a leadership position at ASCPT student and trainee community for past 3 years. Currently, she is serving as an award selection task force. She has conducted research at AIG hospitals, focusing on carbapenem-resistant Enterobacteriaceae in acute necrotizing pancreatitis patients and critically ill patients. So, welcome to Dr. Shravani. Over to you, Shravani.
Good morning, everyone. Thank you so much, Shubham, for such kind introduction. So, good morning, everyone. Let's start our Sunday with such fruitful presentation regarding pharmacokinetics and pharmacodynamics in critical ill patients. So, what we'll learn regarding in this session? So we'll describe how the medication absorption is affected and how the distribution, how the protein binding hepatic flow will be affected in critical ill patients, and how this gradually being affecting the pharmacological response of the drug. So first question, so why do we need a clinical pharmacist in ICU setting? So what is the major role of a clinical pharmacist in ICU setting? So when it comes to critically ill patients, those patients are really at a very high risk of adverse drug events. So these adverse drug events will eventually lead to increased hospital stay and higher costs, right? So when patients are critically ill, it is really difficult to manage such patients. So managing critically ill patient is like solving a Rubik's Cube. So when you solve a Rubik's Cube, each and every step is very much critical, right? So in managing critical ill patients, we need a consultant, we need an intensivist, anesthetist, a physiotherapist, nurse and nutritionist, and also a clinical pharmacist to carefully manage a patient and get a positive outcome from a patient. So when it comes to a clinical pharmacist, it is really very much important that the clinical pharmacist have a good knowledge on pharmacokinetics and pharmacodynamics of drugs. So clinical pharmacist with a knowledge on PK/PD is a real game changer. And also the intensivist needs a help of a clinical pharmacist who can analyze the drugs and who has in-depth knowledge of PK/PD to manage a patient. So there is a study by Leap et al. The inclusion, he concluded that an inclusion of a pharmacist as a member of multidisciplinary ICU team has helped to reduce the incidence of preventable adverse drug events by 60%. So next comes the pharmacokinetics. So what does a pharmacokinetics mean? The movement of drug to the body and divided into 4 major compartments, right? So it is nothing but the game of absorption, distribution, metabolism, and excretion. So when it comes to critically ill patients, the absorption is highly altered, the distribution is altered, metabolism and excretion. So this is nothing but a game of ADME, which is eventually leading to a different the same pharmacological response, but the extent of pharmacological response is different. So in this first topic, we'll learn how the absorption is affected and how the distribution is affected. So we'll learn much in detail about these different pharmacokinetic parameters. Absorption. So what is absorption? Traditionally, absorption occurs when the drug reaches the systemic circulation, or sometimes it reaches the portal circulation, right? In recent years, a new definition is presented in which the drug is assumed to be absorbed when it leaves the lumen and crosses the apical membrane of the enterocytes lining the intestine. So this is a graphical representation of how the drug is absorbed from the GI tract. And when it comes to the factors affecting the GI absorption of the drugs, there are three major factors: physiological properties of drugs, the dosage form, the anatomy and physiology of absorption site and environment. So in this seminar, we'll be largely focusing on the anatomy and physiology of absorption site and environment. So before going into what are the factors that affect the GI absorption, let's learn about bioavailability. Bioavailability refers to the proportion of the substance that reaches the circulation when introduced into the body and is able to have an active effect. So the first parameter is GI perfusion and GI absorption. So now look at the picture. We have two different set of patients. The first patient is stable, which means the patient has an equal distribution of blood flow. But when it comes to critically ill patient will be in hypotension and shock. And it is body's natural physiology that the blood flow to vital organs such as heart, brain, and kidneys is increased. And compared to the blood flow to these organs is increased, and the blood flow to GI tract, subcutaneous tissues, and muscles a bit decreased. So it is clear that the blood perfusion is decreased in GI tract, subcutaneous, and muscle tissues, which leads to decreased GI perfusion. So if the GI perfusion is decreased, the absorption of GI drugs, which we are giving to the patient through orally, will be decreased. So it is ultimately seen that if the GI absorption of the drug is decreased, there will be an therapeutic failure. And next comes vasopressor effect. What is vasopressor effect? When a critically ill patient, the patients will be usually on either dopamine, epinephrine, or norepinephrine. So these dopamine, epinephrine, norepinephrine will decrease the splanchnic perfusion, which will lead to the decreased GI perfusion, and also even this will lead to the decreased GI absorption of the drugs. So even this will lead to therapeutic failure. So there is one such example to have a better understanding about this. So there was one study conducted by Tarling et al. So he observed two sets of patients. So one set of critically ill patients who were not on dopamine, and the other set of patients who were on dopamine. So the both set of patients were receiving oral paracetamol. So they observed the AUC of the drug, AUC of paracetamol in patients with dopamine, and AUC of paracetamol in patients without dopamine. So it was clearly seen that there is significant reduction of AUC oral paracetamol in critically ill patients who were receiving dopamine compared to who are not on dopamine. So it means that the efficacy of the paracetamol is reduced in patients who are on dopamine due to the vasopressor effect. And next comes the gastric pH. So in ICUs, we'll be seeing that patients will be on proton pump inhibitors, H2 receptor antagonists, and IV antisecretory agents given in case of stress ulcer prophylaxis. But this will increase the gastric pH, and many of the drugs which are given orally are either weak acids or weak bases. So if the gastric pH is increased, the bioavailability of the drugs is potentially decreased. So one such example is that ketoconazole and itraconazole. The reduced absorption of ketoconazole and itraconazole by omeprazole, because this will increase the gastric pH, and ketoconazole and itraconazole, these two drugs require acidic environment to increase, for optimal absorption of the drug through the GI. And delayed gastric emptying. So there are various factors that will cause the delayed gastric emptying, starting from burns, multi-system trauma, sepsis, mechanical ventilation, electrolyte abnormalities, hyperglycemia, splanchnic hypoperfusion, opioid and sedative use, and post-operative ileus, traumatic brain injury. So there are vast factors that will cause the delayed gastric emptying. And we know that the drugs will get highly absorbed from the small intestine. So if there is a delayed gastric emptying, so that will indirectly affect the time of absorption of the drug. So there is one such example is paracetamol. The AUC at 60 minutes and Tmax of paracetamol are significantly reduced in critically ill patients compared to healthy patients. And next comes the drug food, drug and drug mineral interactions. So when we see patients in ICU, so they are not able to get feeds through oral. So we usually put a Ryle's tube so that they can, we can give feeds to the patient through that tube. But what happens? So patients are receiving through feeds through that tube. We ultimately decide to give any oral drugs through that Ryle's tube. But what happens is that look at this look at this picture. So this is a cross section of the Ryle's tube. So the blue ones are the drug adhered to the lumen, and the yellow ones are the reduced amount of the drug. And this is the drug lumen. So what happens is that this when you give the medication through the Ryle's tube, that drugs will coat into the to the inner lining of that lumen. So if that coat, there is a reduced amount of the drug which is reaching our body, which means that which will lead to decreased therapeutic response of the drugs. So the enteral feeds. To reduce this effect, the feeding tubes. So we usually flush before giving any kind of oral drug. So first we'll flush, give the drug, and then flush. This is something which we'll follow in critically ill patients who are on tube feedings. And also enteral feed solutions, even this will increase the gastric pH. So if the gastric pH is increased, there is a reduced absorption of drugs which require the acidic environment. So this is something which you can relate with the topic which we have discussed regarding increased gastric pH due to stress ulcer prophylaxis. So one such example is that phenytoin and ciprofloxacin. And next comes the subcutaneous or intramuscular absorption. So yeah, there is a reduced peripheral circulation. So you have we have already discussed in the first step that in case of critically ill patients, there is an increased blood perfusion to heart, brain, and kidneys, and there is a reduced blood circulation to the even peripheral circulation. So if there is reduced peripheral circulation and there is a reduced drug absorption. So if you see here, here is the intramuscular and this is the subcutaneous. So if there is decreased blood flow through these organs, so the absorption of the drugs is also decreased. One such example is that enoxaparin. The anti-TX, AUC, and antithrombin activity in plasma after administration of enoxaparin was significantly lower in critically ill patients with subcutaneous edema. So what happens is that in critically ill patients, there is some kind of subcutaneous edema because patients will be receiving high amounts of IV fluids. So here they compared that two different sets of patients. One set of critically ill patients who has subcutaneous edema and the other set of patients who doesn't have subcutaneous edema. So there is a decreased activity in patients who have subcutaneous edema, which means that there is a decreased absorption of enoxaparin into this patient. And the next comes distribution. So what is distribution? After a drug is absorbed systemically from the site of administration, the drug molecules are distributed throughout the body by systemic circulation. The location, extent, and distribution are dependent on drug's physiological properties and also individual patient characters such as organ perfusion and blood flow. So each and everything is interconnected. The distribution is interconnected to the absorption. Volume of distribution. The concentration of the drug in the before going into what are the factors that affects the distribution, let's learn about volume of distribution. The concentration of the drug in plasma or tissues depends on the amount of drug systemically absorbed and volume in which the drug is distributed. Fluid shift. So just look at this picture. So usually when patients are in critical care unit, they have this phenomenon called fluid shift. So increase in total body water and interstitial, or it is also known as third space fluid. So how does the patients have such third spacing in their arms? So when you look at my hands, these are completely normal. But look at these patients, there is a bulge. So this is called as fluid shift. So what happens? It is, why does it happen? In case of fluid administration, positive pressure ventilation, and in case of hypoalbuminemia and systemic inflammatory response. So if there is a fluid shift in such patients, there is increase in total body water and also the apparent volume of distribution of hydrophilic drugs such as beta-lactam antibiotics aminoglycosides, vancomycin, and linezolid. So volume of distribution is increased. So if the total body water is increased, the apparent volume of distribution of hydrophilic drugs are increased, which means that the peak plasma concentration is decreased and the clearance obviously remains unchanged. So if the peak plasma concentration is decreased, which will lead to the therapeutic failure. Theoretically, this could result in decreased efficacy of concentration-dependent antibiotics, but may result in equivalent or no improve or even improved efficacy in case of time-dependent antibiotics. So we will learn about this phenomenon in later pharmacodynamic session in later slides. And protein binding. So in our blood, we have two major proteins. One is albumin and the other one is alpha-1 acid glycoprotein. So these are the major proteins which are present in our body. And acidic drugs usually bind to albumin and basic drugs usually bind to AAG. So the short form of alpha-1 acid glycoprotein is AAG. So alteration in protein binding is an important phenomenon which will affect the volume of distribution of the drugs. So we have two scenarios here in case of hypoalbuminemia and increase in AAG. So these are usually the responses to an acute inflammatory phase. In case of hypoalbuminemia, so if the albumins are decreased and there is an increased fraction of free drug. So usually a basic acidic drug will bind to albumin. So if the albumin levels are decreased, the serum concentrations and the fraction of free drug is increased of the drugs which will bind to albumin. So if there is an increase in fraction of free drug, there is an increase in pharmacological effect, and which will also lead to increased risk of adverse drug events. And when it comes to the increase in AAG, so it is usually an acute phase reactant in presence of inflammatory stage. Clinicians should consider the impact of low albumin, especially in case of DCLD patients. We usually look that the albumin levels in these patients are really very low. So the clinicians and also the clinical pharmacists should consider the impact of low albumin when using drugs which are highly bound to the albumin, and also consider the dosage reduction or alternative drugs with low or no albumin binding. And tissue perfusion. So we have learned in the previous section in case of absorption that the blood perfusion is decreased, because in critical ill patients the blood will shunt the vital organs. So the regional tissue hypoperfusion, that will lead to decreased delivery of hydrophilic drugs by the blood to the capillary beds. The limit which will limit the drug efficacy at the site of action, especially for non-central organs and peripheral tissues. So you have seen here. And the next case is ECMO, extracorporeal membrane oxygenation. So in case of ECMO, so the patient is literally dependent on ECMO for the respiration. There are two different kinds of ECMO, VV ECMO and VA ECMO. So what happens in case of ECMO? There are different kinds of tubes, and there's a tube in that ECMO. So usually the drugs which are highly lipophilic and highly protein bound get adsorbed. So what is the difference between absorption and adsorption? So look at this picture. So the first picture is absorption. Absorption means the drug will be entering into that surface, into that foreign body. But when it comes to the adsorption, the drug particle will coat into that tube. So that is called absorption. So in case of ECMO, the highly lipophilic drugs and highly protein bound drugs these drugs will lead to increased absorption. So if the adsorption is increased, the plasma drug concentrations are decreased. So the ultimate effect is that there is a decreased therapy. There is a decreased therapeutic response, which will lead to therapeutic failure. And next comes the sequestration. So this is called a sequestration. So the highly lipophilic and protein bound drugs will get sequestered. So sequestration can decrease over time due to saturation of ECMO circuit, and this may also result in drug release from ECMO after stopping the medications. therapeutic failures, and insufficient concentration of antimicrobials, analgesics, and sedatives, and even anti-epileptics have been described for ECMO patients. And one such example I would like to give you is that in case of ECMO patients, usually in critical ill patients, we choose fentanyl. But when it comes to ECMO, the fentanyl will get coated into the lumen of that ECMO circuit. That is the reason we choose morphine over fentanyl in such cases. And the next comes the absorption, the metabolism. Drug metabolism occurs in different variety of body tissues, including GI tract, kidneys, liver, lung, and brain. But the predominant site of drug metabolism is liver. Hepatic metabolism. So we have two different kinds of hepatic metabolism. The phase one, which use cytochrome P450 enzymes, and this will convert. This will increase the polarize the medications, and that will, which is suitable for the elimination through urine. So in phase one, we have oxidation, reduction, and hydrolysis. And in phase two, we have glucuronide conjugation, acetylation, methylation, sulfate conjugation. So these are removed from our body through biliary elimination of fecus. And in phase one reactions, the drugs are eliminated through renal elimination. Hepatic clearance. The volume of the blood that is completely cleared by the body cleared by the liver per unit time. The ability of liver to remove the drugs from systemic circulation is directly proportional to the blood flow through the liver and the hepatic extraction ratio of the drug. So it is clear that the more the blood flow to the liver, there is more ability of the liver to remove the drugs. And next comes hepatic extraction ratio. It is the fraction of the drug that is removed from the blood after the one first pass through the liver. And there are three different classifications: the high hepatic extraction ratio drugs, intermediate, and low. So the hepatic clearance of drugs with high extraction ratio primarily depends on the blood flow and less sensitive to changes in the liver function. Conversely, the hepatic clearance of the drugs with low extraction ratios, example, phenytoin and warfarin, is less sensitive to the changes in the hepatic flow and more influenced by the changes in the liver function. Knowing whether the drug has an higher or lower hepatic extraction ratio, therefore, can be useful in predicting the influence of changes in hepatic blood flow and also function on hepatic drug clearance. And hepatic enzymatic activity. So the alterations in CYP450 enzyme, cytochrome P450. So this is an enzyme which is present in phase one reactions, can lead to prolonged reduction of therapeutic effects of parent compounds and increased burden to toxic metabolites, a delayed response from prodrugs that require hepatic enzyme. So these prodrugs require such enzymes to convert into active drugs. So if there is any alteration in CYP450 enzyme, there is a delayed response from the prodrug that required these enzymes to convert into pharmacologically active compound. So there are different scenarios which will affect the enzymatic activity. So first comes the severe burn injury. In severe burn injury patients, the function of phase one reaction is decreased, yet the phase two is not affected. And when it comes to the renal dysfunction, so renal dysfunction is indirectly correlated with the function of the liver. So there is a decrease in phase one reaction and also the phase two reaction. When it comes to cirrhosis, the number of hepatocytes are reduced in case of cirrhosis. So this will lead to reduced enzymatic activity. And also next comes the cholestasis. Delayed biliary excretion of drugs has been found to impair cytochrome P450 function. So a hepatic enzyme function will have a different critical ill patients have different effects, and also the decrease of phase one and phase two reactions. Hepatic blood flow. In case of severe sepsis, septic shock, cardiac output can decrease or increase. Decreased cardiac perfusion due to microcirculatory dysfunction. And in case of cirrhosis and also vasopressors, this all will cause decrease in hepatic blood flow. So if there is decreased hepatic blood flow, decreased clearance of high hepatic clearance. is observed. And next comes the elimination. Renal elimination. The glomerular filtration is the primary mechanism responsible for the renal clearance of most of the drugs. And glomerular filtration rate is directly proportional to the renal drug clearance. So we have a healthy kidney, and then comparing it with the AKI and also CKD. So AKI and CKD are two. AKI means it is just the onset of kidney dysfunction in a very short period of time, and next comes the CKD. So that is a progressive disorders, and despite AKI being the common in critical ill patients, it is important for clinicians to consider the conditions that can increase or augment the renal clearance of medications. So in case of trauma, sepsis, surgery, burns, and vasopressors, there is an increased blood flow, which means there is an increased clearance of drugs. So there are different steps for assessing and adjusting the drug regimens in patients with AKI. So we have Cockcroft-Gault equation. So we usually use Cockcroft-Gault equation to calculate the creatinine clearance in any kind of patients and then adjust the dose according to that. And the stepwise approach to adjust the drug regimens in case of patients with AKI and CKD. So first we'll obtain the relevant history and also clinical information. And also the next step is to estimate the glomerular filtration rate. So once you have a patient, then with a CKD or AKI, so you will collect the past medication history, medical history, and all the other required laboratory data, and then estimate the creatinine clearance. So you can use the Cockcroft-Gault equation, and then review the medications which require the dosage adjustment and also individualization of the treatment according to patient's body, and then calculate the individualized treatment regimen. So you have to determine the treatment goals, calculate the dosage regimen based on the pharmacokinetic characteristics of the drug and patient's volume status and eGFR. And after that, you have to monitor the patient. So you have adjusted a drug to a patient. And the next step we have to see is monitor the patient, whether the patient is responding to the treatment or not. Monitor the parameters for drug response and toxicity, and also monitor the drug levels if available. And revise the regimen. Adjust the regimen based on the drug response and change in patient status as warranted. Yeah. So this is just a brief information regarding the dosage adjustment of drugs in case of AKI and CKD patients. You'll learn a lot about this in next upcoming sessions. Hepatic elimination. The liver handles the majority of body metabolic processes. It is capable of metabolizing many drugs, generally producing compounds that are more polar and more easily excreted. The enzymes in the liver are able to form conjugates, hydrolyze, reduce, and also oxidize the drugs. One of the liver's most important function is to convert non-polar, water-insoluble drugs into polar, water-soluble compounds that can be excreted into a urine or bile. And then the last topic on pulmonary elimination, in the topic of elimination is pulmonary elimination. Pulmonary type of alveolar cells or Clara cells contain various enzymes that are similar to those within the hepatocytes. The contribution of drug elimination from the lungs is really negligible and difficult to quantify, but it is really very much important. Some drugs are exhaled unchanged, terminating their effect and eliminating them from the body. In this scenario, elimination increases with alveolar ventilation. More volatile anesthetic agents have minimal in vivo metabolism and are eliminated via exhalation. So these are the reactions that takes place in the lungs. Phase one reactions, oxidation. So phenobarbital and nortriptyline. So these are the drugs that undergo phase one reactions in lungs. Reduction and also hydrolysis. So these are the different kinds of drugs that undergo elimination through through lungs. And this is a graphical representation of how different pharmacokinetic parameters will affect the absorption, distribution, metabolism, and excretion. So ultimately, we have to avoid two such scenarios in the patient. We have to avoid adverse drug events, and also we should also avoid therapeutic failure. We have to make sure to individualize the regimen in such a way that patient have more efficacious treatment. So we have learned about absorption, distribution, metabolism, and excretion. Okay, so these are the steps which we have learned till now, and then we'll go into the what is the pharmacological response of these drugs. So now we'll learn about the pharmacodynamics. Pharmacodynamics can be defined as quantitative relationship between observed tissue, observed tissue concentration of the active drug and its pharmacological effects. For antimicrobials, the term pharmacodynamics describes the relation of the drug concentration to the ability of antibiotic or antifungal to kill or inhibit the growth of a pathogen. So in this section, we'll learn more about antimicrobials. So pharmacodynamics of antibiotics. So we know that pharmacodynamics are divided, PK/PD indices are divided into three different types: concentration dependent antibiotics, time dependent antibiotics, both concentration and time dependent kill characteristics. So what does concentration dependent antibiotics mean? The ratio of peak drug concentration to MIC. So what does a concentration dependent killing means? The more the concentration of antibiotic in our body within a less period of time, the more the killing effect. The concentration dependent. So let's look at this. The concentration dependent antimicrobials, for which increased concentration progressively enhance the antimicrobial killings. So one such example for such concentration dependent killing antibiotics are aminoglycosides. And then comes the time dependent antibiotics, the time dependent antimicrobials, for which the prolonged duration of effective drug exposure leads to greater antimicrobial killing. So the more the drug stays in our for the longer time the drug stays in our body, it has the more efficacy. For example, beta-lactam antibiotics. So that is the reason we usually give prolonged infusion of beta-lactam antibiotics and also carbapenem antibiotics, so that the prolonged duration of antibiotic is within the body, the more therapeutic effect is seen in the patient. And the next comes both concentration and also time-dependent kill characteristics. Both concentration and time-dependent kill characteristics are really very much vital to show the bactericidal or bacteriostatic effect in such antibiotics. So examples are fluoroquinolones and glycopeptides. So these are the classification of drugs: aminoglycosides, lipopolypeptides, lipopeptides, lipoglycopeptides, and fluoroquinolones. So these are the time dependent and also concentration dependent, and also these are time dependent and concentration dependent. And when it comes to penicillin, cephalosporins, carbapenems, so these are the time dependent antibiotics. Pharmacokinetics and pharmacodynamics of heparin. So we know that heparin is administered both as intravenous and also subcutaneous. And however, the bioavailability of IV heparin is 100%. However, the bioavailability of subcutaneous administration of heparin is only 30 to 70%. And the protein binding nature, it also binds to the plasma proteins, endothelial cells, and macrophages. And the half-life is unchanged in urine, and the half-life is dose dependent. Pharmacodynamics of heparin. So this is a pictorial representation of a mechanism of action of heparin. So we know that heparin prolongs the activated partial thromboplastin time, APTT, and also we have to measure the anti-factor X10A levels to know the efficacy of the heparin, and also the enoxaparin. So one such example which we have covered in the previous session is that anti-10A AUC values and on anti-thrombin activity in plasma after administration of enoxaparin was significantly lower in patients with critically ill patients with subcutaneous edema to patients who doesn't have subcutaneous edema. So here it shows that how the subcutaneous edema in the pharmacokinetic parameters will affect the which will affect the pharmacological response of the drug. And next comes therapeutic drug monitoring. So we have learned a lot about pharmacokinetics and pharmacodynamics. So, but why is therapeutic drug monitoring very much important? So therapeutic drug monitoring is very much important in order to monitor whether the drug which we are giving to the patient is reaching the therapeutic levels or not. So if the drug levels are suboptimal, then we have to make sure to adjust our treatment regimen so that it reaches the therapeutic levels and also show its effect. Then what is the purpose of TDM? This is to keep the concentration of particular drug in a specific therapeutic range to achieve the maximum efficacy and minimum toxicity of drug being administered. The therapeutic range represents the range between the minimum effective concentration and minimum toxic concentration. The ratio between the minimum toxic concentration and the minimum effective concentration is defined as therapeutic index. Now we learn about few drugs and also the therapeutic ranges of such drugs. So vancomycin. Vancomycin is most commonly used in hospital settings. So vancomycin, the TDM range is 15 to 20 mcg per liter. And then comes the voriconazole. So when it comes to vancomycin, we see that patients receiving prolonged period of vancomycin because we want to monitor the TDM range because vancomycin is highly nephrotoxic. We have to make sure that we dose the patient in such a way that it doesn't harm the kidneys. I mean, it doesn't reach the drug the serum concentration at toxic levels. And the next one is voriconazole. The TDM range is 1 to 2 mcg per liter. And digoxin, even this is something which we usually see in cardiology units. Measuring digoxin is very much common, So the TDM range is 0.8 to 2.0 ng per liter, nanogram per liter. And tacrolimus is something which we see in transplant units. Tacrolimus, 2 to 4 nanogram per ml. And carbamazepine, the normal range is 4 to 12 mg per liter. So why these TDM ranges are so important? So if the drug level falls, if there is a patient and you want to see the TDM range in this patient, and we have sent a sample, and vancomycin level in that patient is the 10 microgram per liter, that means that it is below the required range. So if that is below the required range, there is a chance of therapeutic failure. So we are not benefiting the patient. In such cases, we have to adjust the doses in such a way that the drug concentration will fall between 50 to 20 mcg per liter. And then if you want, if there is some other patient and you have sent the samples for vancomycin levels, and the vancomycin levels in that patient is 25 to 30 mcg per liter, which means that that is a toxic level that will lead to different kinds of adverse drug events and toxic side effects. Okay, so in order to avoid that, this is something which we usually follow, that we have to do the therapeutic drug monitoring. Analytical considerations for TDM of aminoglycosides and vancomycin. The knowledge of relationship of time the drug dose is administered compared to the trough and peak concentration is very much important. So when do we take the peak concentrations? When do we take the trough concentration? So in case of aminoglycosides and vancomycin, the trough specimens are collected just before the next dose. For conventional multiple dosing, and if you want to see the peak concentrations, so you have to take the sample after the 30 to 60 minutes after the administration of intravenous drug. I mean, after the completion of intravenous administration. And next comes analytical considerations for TDM of immunosuppressants. So the whole blood sample should be taken in case of if you want to see the drug levels of immunosuppressants such as cyclosporin A, tacrolimus, sirolimus, and everolimus. Because immunosuppressants are really highly protein bound and they distribute extensively between plasma and also erythrocytes. In recent years, the peak concentration of CSA, which means cyclosporin A, have been correlated with clinical outcome, and many studies have found that peak concentrations, the sample drawn after 2 hours of oral dosing. So if I have taken the medication at 12 o'clock, 12 p.m., then the sample to be taken after the oral dosing at 2 o'clock, that should be done. So this is called as C2 monitoring. So this correlate with the better outcomes and also with the total drug exposure and clinical outcomes as compared to the trough concentration. So in case of cyclosporin A, choosing a peak concentration and relating it with clinical outcome is very much more favorable compared to choosing trough concentrations. So this is the end of therapeutic drug monitoring. Now let's go through few Q&A session questions. So first question is, in critical ill patients, which factor which factor commonly affects the drug clearance? Option A, age. Option B, gender. Option C, renal function. And option D is BMI. So what is the major factor that affects the drug clearance? Let's look at the answer. Renal function. In critically ill patients, renal function is a common factor that significantly affects the drug clearance. Impaired renal function can lead to reduced drug excretion, necessitating the dosage adjustments to avoid toxicity and ensure efficacy. So if there are two different patients, one patient has a good renal function and the other patient has reduced renal function, which means that creatinine clearance is very much low. So I cannot give the same dose to both of these patients. If patient A has normal function, you have to give them a normal dosing. When it comes to patient B, whose creatinine clearance is low, you cannot give the same dose which you have given to the patient A, because because the renal function is reduced, urine output might have been reduced, the creatinine clearance is reduced, which means that even the excretion of the hydrophilic drugs which requires a renal elimination is also reduced. So if we dose the patient same as patient A, that will lead to accumulation of drugs in our body, so which will lead to toxicity, and also the patient will experience side effects. So it is really very much important that you have to adjust the doses according to patient's kidney function. And the next question, which strategy is commonly used to adjust drug dosing in critical ill patients based on altered pharmacokinetics? So it is just a correlation to our first question. So which strategy is commonly used to adjust drug dosing? So when you relate this question to the last topic which we have seen, that is monitoring the drug concentrations. So let me just give you the options. Understand using standard dosing regimens, monitoring the drug concentrations frequently, administering drugs only during the day, administering the higher doses without adjustment. So the option is monitoring drug concentrations frequently. So in critically ill patients, monitoring drug concentration frequently is a commonly used strategy to adjust the doses in case of based on altered pharmacokinetics. So this approach will ensure that drug levels remain within the therapeutic range and also minimize the risk of toxicity. So the only ultimate goal, the major conclusion of this chapter is that we have to avoid toxicity, we have to avoid therapeutic failure. We want a therapeutic success in this patient. Okay, so we have to perform a therapeutic drug monitoring. That is an ideal approach to see the drug which we have given have reached the drug concentration in our body or not. So this approach ensures that the drug levels remains within therapeutic range and minimize the risk of toxicity, given the complex changes in drug metabolism and clearance that occur in these patients. Let's go to question number 3. Which renal function parameter is often used to adjust drug dosing in critical ill patients? So these are the series of questions. You just have to correlate. Option A is serum sodium levels. Option B, glomerular filtration rate. Option C, calcium levels. Option D, red blood cell count. So what is correct option? So I think it is a bit easy and it is really evident that we look after glomerular filtration rate. So in critical ill patients, the GFR is often used to adjust the drug dosing. And GFR is a key indicator of kidney function and helps determine how well the kidneys are clearing from the bloodstream. Adjusting the drug doses based on GFR will help prevent toxicity and ensure that the drug remains within the therapeutic ranges. So I think this is completely clear. And the last question, how does increased volume of distribution affect antibiotic dosing in critical ill patients? So here you can take the example of hydrophilic drugs. So we have discussed earlier that what happens if the volume of distribution of hydrophilic drugs are increased. So you can, if you remember that there is an edema in the hands, which means that the fluid is being accumulated in our body. So there is a third spacing. So if there is a third spacing, there is a higher area for this hydrophilic drugs to get distributed. So higher volume for this hydrophilic drugs to distributed. So what happens if the volume of distribution of these drugs are increased? Question number 1. Requires higher doses to achieve therapeutic levels. Option 2. Decreases the risk of toxicity. Option 3. Shortens the dosing interval. And option 4. Improves the tissue penetration. So what do you think? So here in case of hydrophilic drugs, there is increased volume of distribution. There is a larger area. So for the drugs to get distributed. So if volume of distribution of these hydrophilic drugs are increased, the peak plasma concentration of these drugs are decreased. So which will lead to therapeutic failure. That is the reason it requires higher doses to achieve therapeutic levels. In critically ill patients, there is an increased volume of distribution. Typically requires higher doses of antibiotics to reach therapeutic levels. This is because the larger VD means that the drug is being distributed more extensively throughout the body, and the higher dose is needed to ensure that adequate concentrations are present in the target tissues and fluids. So these are few references. So I have gone through different articles and different textbooks to make this PPT. And these references which I've mentioned here are, if you go through those references, it is very much very much useful. So I recommend you to go through these articles so that you can increase your, that will help you gain your more knowledge and also correlate such situations in your critical care settings during hospital work. Thank you so much. So if you have any questions, you can reach out to us at fcpiofficial@gmail.com.
Thank you, Shravani. Thank you for this wonderful session. So this ADME and pharmacodynamics will definitely help us in doing our clinical pharmacist job. So routinely we use various drugs in critical care settings. So my first question to you will be, what do you think about the crushing of oral medications, and what parameters or what things we should look for while crushing any oral medications?
Thank you so much, Shubham. So that is a really very much interesting question, and it is one of the challenge when we encounter such situations. And when it comes to oral formulations, there are immediate release drugs and there are prolonged extended release drugs. So when it comes to immediate release drugs, we can press those immediate release drugs. But when it comes to prolonged release drugs, those tablets are coated. So it is designed in such a way that is released in our body for a very long period of time. So ideally, we are not supposed to crush any extended release drugs. Okay, because if we crush that, the outer coating of that is removed, and when we administer that, the higher doses is reaching the patient in a very short period of time, so that have immediate effect, where the tablet's major motto is to show its effect for 24 hours. And the next one is that when you crush the medications, I have seen that nurses crushing all those 4 to 5 medications, crushing in one mortar and pestle and administering that medication to a patient. And that is not an ideal scenario. We should never do that. We should always make sure that we administer one medication at one time. Okay, because we don't know the incompatibilities the drugs have while crushing all those medications. So make sure that if you have, for example, if you have 4 medication A, B, C, D, so make sure that first flush it, crush the medication A, dilute that, administer that, and then flush it and give medication B, flush it, give medication C, flush with NS, give medication D, and then flush it. So flush before and after each and every tablet is very much important, because we don't know the kind of incompatibilities, the clogging up of the medication inside that trials tube. We don't know what happens. So it's better that we make sure that we flush before and after administration.
Right. Thank you, Shravani. I recently had one case where they were crushing the oral pantoprazole. So it is commonly seen in ICU settings that they crush oral pantoprazoles. So the next question is, how you deal with the drug-drug interactions and drug-food interactions in ICU settings?
Okay, that's an interesting question. So when it comes to ICU settings, patients will be on feed tube. with feeds.
Yeah.
So in such patients, it's better that we stop those feeds for 1 to 2 hours and give the medication, because we have seen that these tubes will increase the gastric pH. So if this gastric pH is increased, that will ultimately decrease the absorption of drugs, which will require an acidic environment. So it's better that we have to stop the feeds for 1 to 2 hours and give them, make sure to administer the medications which requires medication with an empty stomach. So it's better to stop that and give the medication, and after after 1 hour, and then start the medications.
Thank you, Shravani. Thank you for this wonderful session.
Thank you so much, everyone. So let me just know if you have any kind of specific questions. I'm available on LinkedIn, named Shravani Trout. So please reach out to me in case of any questions. And also you can reach out to fcpiofficial@gmail.com.